Good evening, everyone. It is indeed a great pleasure for me, on behalf of SANEM, to invite you to this organized session of Bay of Bengal Economic Dialogue 2021. Uh, Today's session and this session is about deepening health sector cooperation in the Bay of Bengal region. And it is a great pleasure of ours that as a chair, we have Dr. Ali Mehdi, Senior Visiting Fellow, Indian Council for Research on International Economic Relations, New Delhi, as the chair. Special remarks will be provided by Professor T.C. James, Distinguished Fellow, RIS, New Delhi. And we also have with us Dr. Mushtaq Chaudhuri, who is convener Bangladesh Health Watch and professor of clinical population and family health, Columbia University School of Public Health. We have a set of very distinguished panelists with us as well. With us today, we have Dr. Karma Lazine, Director, Department of Public Health, Bhutan. We have Dr. Rumana Haq, Professor, Department of Economics, University of Dhaka, Bangladesh. We have Dr. Reji K. Joseph, Associate Professor, ISID, New Delhi. We have Dr. Samir M. Dixit, co-founder and director of Research Center for Molecular Dynamics, Nepal. And we also have Dr. Tushani Darbera, consultant community physician, Sri Lanka. It is a great pleasure for us on behalf of SANEM to welcome you in this very exciting session, because it's a very exciting and pertinent session at this moment, against the backdrop of COVID-19. Before we start the session, a few logistics that I would like to mention. One is may I kindly request the panelists to keep their videos on, and for other participants, if you could kindly keep your microphone and videos off, that would be appreciated. And if you have any question, you can either type it in the chat box, or you can also use the raise hand option. The chair will come to you with his comments and with his when to ask the question, and you can introduce yourself at this moment, or either you can type your question in the chat box. So with this, I would like to request the chair to begin the session. Honorable Chair, over to you.
Thank you, Professor Vidisha. Hello and a very good evening to everyone. I welcome you all to the last session of the day, but hopefully a very promising one on deepening health sector cooperation in the Bay of Bengal region as part of the Bay of Bengal Economic Dialogue 2021, focused on post-COVID-19 challenges in the region. As you all know, the COVID-19 pandemic has highlighted and intensified systemic fragilities not only in health, but social and economic systems at large. Low and middle income countries like those in the Bay of Bengal region have been the worst affected, and many are now even less prepared to prevent or tackle potential pandemics in the future. Global and regional cooperation to strengthen pandemic prevention and preparedness capacities in these countries in particular is a critical imperative of our time to prevent national, regional, as well as global systems and economies from slipping into a deeper crisis. The COVID-19 pandemic has clearly highlighted that we live in an era in which local problems swiftly become global challenges. And to quote the European Commission President, none of us will be safe until everyone is safe. So with this brief context, let me first of all congratulate the organizers for putting together a fantastic agenda for the session and bringing together highly distinguished speakers from the region to share their views on 4 key themes. Number 1, the scope for regional cooperation in the region's health sector, the best practices from the region's health sector, particularly in terms of dealing with the ongoing COVID-19 pandemic. Then what are the regional funding options that could be considered? And finally, how can we develop a regional plan and a network of health cooperation specialists who can help strengthen responses to future pandemics? As Professor Vidisha has already said, that we will have special remarks by 2 very distinguished speakers, Professor T.C. James and Dr. Mushtaq Chaudhuri. In 7 to 8 minutes each, they will introduce the key themes to the audience in detail and set the tone for the discussions that will follow. Professor T.C. James is a distinguished fellow at the Research and Information System for Developing Countries, that is RIS, in New Delhi, and Dr. Mushtaq Chaudhary is the convener of Bangladesh Health Watch and a professor of population and family health at the Mailman School of Public Health at Columbia University in New York. And then subsequently, we have 5 distinguished panelists who will share their views within 7 minutes each on the key themes, followed by almost an hour of question and answer session. So the idea is to engage with the audience and have a lively discussion around the key themes of the session. So please feel free to share your questions in Zoom's chat session, or you raise your hand, as Professor Vidisha said. Your questions can either be general or addressed to specific speakers. In case of the latter, kindly also mention the specific speaker whom you would like your response from. So Professor Vidisha has already introduced the distinguished panelists, so I will not do that again. So may I now request, without any further delay, Professor T.C. James to deliver his special remarks. Professor James.
Thank you. Esteemed Dr. Ali Mahdi, Dr. Mushtaq Chaudhary, Dr. Karma Lehasin, Dr. Rumana Haq, Dr. Reggie Joseph, Dr. Samir Dikshit, Dr. Tushani Debera, and dear colleagues and friends. Good evening to all of you. Like other parts of the world, BIMSTEC region has also been seriously affected by the COVID-19 global pandemic. About 12 million persons in the region got afflicted with the disease, and more than 169,000 lost their lives. While almost all countries in the region have, through various timely measures, brought down the spread and largely contained the disease, but there are still pockets in countries where the pandemic is continuing. In this context, this session on deepening health sector cooperation is timely and is of great importance. Our actions are of great significance as we represent around 1.5 billion people, that is 22% of the global population, and our economies together are of the size of $2.7 trillion. Let us have a look first at the contributing factors or rationale of healthcare cooperation. Infectious diseases can spread through air, water, or through blood-feeding arthropods such as mosquitoes, ticks, and fleas. Geographical boundaries are different from political borders, and viruses and bacteria do not care for the latter. Since our countries share borders with each other, we need to have increased cooperation in containing infectious diseases such as the present pandemic. So, the second factor is the commonalities in our lifestyles, such as food habits, social structures, and practices, and so on. This is particularly so in border areas of each country. Also, people more or so in the border districts share many physical traits which make them vulnerable or not vulnerable to certain infectious, irrespective of the border. In the case of global pandemic like COVID-19, this may not be very relevant, but in case of many other epidemics, this is a factor to be accounted for. A third important factor that prompts more cooperation in healthcare amongst the BIMSTEC nations is that they are generally in the bottom half of health indicators like life expectancy, child and maternal mortality rates, number of healthcare personnel and facilities, etc. The disease burden profiles also have much similarity. Added to these three is the economic factor. All the countries are developing countries. They have to be extremely careful about using their scarce resources since the demands of development are greater on them. There are competing claims among sectors like infrastructure, manufacturing, transport, and social sectors like education. Cooperation in healthcare can certainly reduce expenditure by sharing many facilities and resources. What should be the scope of such cooperation? BIMSTEC meetings had in the past also many times discussed healthcare cooperation, and some progress has been made in that. For example, a telemedicine network to improve regional cooperation in healthcare among BIMSTEC nations was launched at the JIPMER Puducherry in 2017, titled JIPMER BIMSTEC Telemedicine Network. Its objectives include sharing of knowledge and promoting standardization and quality control of health practices. But in view of the almost unprecedented pandemic, we need to explore more such areas. We have a very eminent panel which can tell us quite a lot about such cooperation with case studies of best practices. I will, however, like to point out some of the areas which can be considered, though many practical issues will crop up when we attempt the same. One, which can be considered on a one-to-one basis between neighboring countries and in a limited way is sharing of healthcare services in the border districts. Countries certainly will have to take care of their security concerns, but still this is a doable thing according to me. I have seen that in many borders, people-to-people interactions and movements are common, and this can be promoted carefully. Certainly, policymakers have to accept the fact that human beings are essentially good and trustworthy. Another area where cooperation can be considered is common health insurance so that patients can get health care in any of these countries when they travel and for specialized treatment. At present, many a time, patients from neighboring countries who seek treatment in another BIMSTEC country face the problem of payments. Enabling digital transactions and digital payments of medical bill, etc., can enable easy access to specialty healthcare in other countries. But harmonized systems in health insurance, allowing insurance companies to operate across borders, like in the European Union, can push cooperation more. A third area where cooperation is required is pharmaceutical R&D. We have already felt the need for faster vaccine development. The countries have also been cooperating in vaccine distribution. India has adopted a neighborhood first policy in its vaccine program, which envelop the BIMSTEC countries. This can be further extended to cooperation in drug research and development, which is a highly resource intensive area. Harmonization and convergence of regulatory approval processes can reduce costs and save time. Cooperation can optimize the expenditure, can also contribute to capacity building in countries that lack the same. While BIMSTEC countries have grown in the manufacture of bulk drugs and formulations, the region is almost entirely dependent on import of medical devices. The regional value chains in health products is not developed. Given geographical proximity, development of inter-BIMSTEC supply chain in medical products and services, especially in the post-COVID rerouting of medical supply chain, can offer advantage to all countries. The issue needs to be explored in depth. For handling future pandemics, we can also learn from each other's experience and some of the best practices that we have seen recently. The countries already had experience with containing epidemics like H1N1, Nipah, etc. in the past. Now we have the COVID-19 experience. The practice and protocols will have to be contextual. They may also differ from country to country, but there are lessons which can be taken. During COVID-19, countries like India adopted the strategy of containment, mitigation, and fast tracking vaccine development. It involved both non-pharmaceutical prevention strategies like closure of institutions and, of course, pharmaceutical interventions. India strictly enforced lockdowns and social distancing, along with new practice of wearing masks and extensive use of sanitizers, besides frequent washing of hands, etc. The strategy included surveillance and screening of foreign and domestic passengers, intense contact tracing, testing, quarantine, isolation, and hospitalization, and so on. Traditional medicine was also employed with a focus on boosting natural immunity of people. The pandemic handling was also a lesson on how, besides health personnel, scientists, technologists, manufacturers, transporters, etc., rose to the occasion and worked as in a war for producing technologies with medical equipments and reaching them to the destination on time. Electronic health reporting and health information management systems were developed and employed in record time. Massive mobilization of public communication with use of technologies was something unheard of in the past. I'm sure the panelists will tell you more about the experience of countries of our region. This will all form part of our future cooperation programs. I only attempted to point some of the areas which can be explored further. Regional cooperation in healthcare has to rise above politics and demand firm commitment from people and academia. It's an area of partnership and collaboration. The demand-supply conditions also demand greater regional integration to face future pandemics. Thank you, organizers, for giving me this opportunity. Thank you.
Thanks a lot, Professor James, for your sharing your insights. They're all extremely useful, and I hope that the audience as well as the speakers will raise them further. So, without attempting to summarize what the speakers will say, I will now move on to the next speaker. I'm very glad to invite Dr. Mushtaq Chaudhry to share his views with the audience here. Dr. Mushtaq Chaudhry.
Okay, thank you, Professor Ali Mahdi, and also Professor Bidisha for introducing me and also for inviting me to this very important meeting that you have been holding for the last 3 days. Over the last 3 days, you have been talking about the post-COVID challenges in the Bay of Bengal region and how this can be mitigated through different innovative activities. And I'm happy that today you are also having a session on health. And I'm very happy to be part of this particular session. So thanks, Sanam, for inviting me to be part of this. May I have the first slide? I have a few slides to share with you.
Dr. Mushtaq, do you want to? Yes.
Yeah, if you can share the screen.
Yeah. Okay, thank you. So I will be, between 2009 and 2013, I was the Asia head of the Rockefeller Foundation based in Thailand. And one of the responsibilities I had was to work with a regional network called the Mekong Basin Disease Surveillance, which is the MBDS in short, and which works in the 6 countries of the Mekong Basin. I was so amazed to see how these countries, many of which are sort of at kind of a loggerhead politically, but when it comes to the question of health, they have been working together. Even as I will show you, how they have set up the cross-border surveillance sites and really working sort of very effectively on doing surveillance on specific diseases and also the outbreaks. And may I have the next slide, please? So this is the Mekong Basin Disease Surveillance, the MBDS I was talking about. And the 6 countries in the Mekong region are the following: Myanmar, as you can see, also China, Vietnam, Laos PDR, Thailand, Cambodia, and also Vietnam. So these are the 6 countries in which the MBDS is working. And can I have the next slide, please? And this MBDS was set up through a signing of a MOU, a Memorandum of Understanding, by the health ministers of the 6 countries in 2001. So that's the time that this MBDS came into being. And you will be happy to know that the MBDS is still there and very powerful and working effectively. Next, please. So the MBDS, there are many things that the MBDS does, and one of the major activities of the MBDS is the cross-border cooperation. And as I will show you in the next slide, next slide, please, that these cross-border sites are there between the countries of the Mekong Basin. So you can see that between China and Vietnam, for example, there are 4 cross-border sites, and between Laos and Thailand, there are 6 cross-border sites. So these are the sites where the disease the disease outbreak is followed up, and the information is shared between the countries, between the neighbors. Next, please. I'll go quickly. So this one shows the frequency of the cross-border information exchange. So depending on the cases, the information is shared in some cases within 24 hours. Some of the information are shared every week, and some of the information every 5th day of the month, and so on. So these are the kind of schedule of exchanging information on the diseases in the countries, and these are shared among the countries, particularly with the neighbors. Next, please. Next. This the MBDS also produces different kind of material, including posters, for example, on biosecurity and biosafety, and these are translated into the country languages in the language of the 6 countries. Next, please. Next, please. This one shows how the outbreak investigations are being done, and this is a kind of exercise, the photographs from exercise, and some of these pictures are very familiar nowadays with the COVID. Next, please. So this one, this table shows the COVID situation in the Mekong countries, and in comparison with Bangladesh and India. Apart from Myanmar, as you see on the top 6 countries, apart from Myanmar, which is looks like a kind of a outlier, the COVID situation is very much under control in all these 6 countries, and even in Cambodia or Laos, for example, there hasn't been any death at all. In Thailand or Vietnam, the number of deaths per million population has been very, very low. But compare this with their neighbor, such as India and Bangladesh, this situation is much worse. So I'm not saying that the MBDS has really caused these, but I'm sure that the preparation work, the preparatory activities that the MBDS has started in those countries had some role to play in having these 6 these MBDS countries to have the COVID-19. The situation is kept under control. Next, please. So, there has been a lot of evaluations and a lot of writing about the MBDS, and one of the reasons for the success that has been shown is that this is being seen as a social movement. And as one of the evaluationists has commented, that the friendship, trust, and partnership built among the people involved are social capitals gained from MBDS. So MBDS was a pioneer in this regional disease surveillance, And after the MBDS, there has been similar kind of networks started in Southern Africa, in Eastern Africa, and in the Middle East. In the Middle East, for example, the network works between Israel and the Palestinians, and also Jordan, the three countries that are part of that. So what shows that even though there are so much of political problems, but when it comes to the question of health, they have come together to really save their population. Next, please. So yes. So do you have any lesson for our region? So that's the thing that I wanted to sort of bring to your attention. Next, please. In 2009, when I was with the Rockefeller Foundation, we tried to set up a kind of a One Health sort of alliance in the Asian countries, and we also had a meeting in Jalpaiguri in West Bengal in 2009, where we sort of formed the what you call the OHASA, One Health Alliance for South Asia. But unfortunately, because of political problems, this hasn't really moved at all. So it has kind of had a neonatal death, unfortunately. Next, please. Now, with the COVID there, and with the increased attention being given on health and also on disease surveillance, do you have any role for disease surveillance in the Bay of Bengal region, between the countries like India, Bangladesh, Myanmar, Thailand, and so on, which will really benefit the people in this region? And this is something that I wanted to bring to your kind of attention for discussion for the panelists to think about, and actually pressurize the governments to really go for some kind of even loose surveillance system that will do kind of surveillance of specific diseases in the region. And finally, with a few lines, next please, with a few lines from Tagore, his famous poem, where the mind is without fear and the head is held high, where the world has not been broken up into fragments by narrow domestic walls, let my region awake. So with these few words, ladies and gentlemen, Sanem, I want to thank Sanem for inviting me, and I wish this conference a big success, particularly this panel on health. Thank you for the opportunity. Thank you.
Thank you so much, Dr. Mushtaq Chaudhary, for highlighting the lessons from the Making Basin region. I think this is very important. Actually, I was going to say this in my initial remarks itself, that we also need to learn from other, the initiatives in other regions. And I think what you've highlighted from a very nearby region is very, very relevant, and the kind of impact that it has had in terms of the COVID-19 pandemic is really remarkable. So thank you so much for your kind words. So may I now move on to the panelists and invite Dr. Karmal Azim, our first panelist, who is a director at the Department of Public Health within the Ministry of Health in the Royal Government of Bhutan. Dr. Karmal Azim, the floor is now yours.
Thank you, Honorable Chair, and the distinguished guests of honor who just spoke, and all the distinguished panelists. It's a privilege and honor for me to be part of this panel discussion, and I'd like to acknowledge the BIMSTEC Secretariat for organizing this session on public health. On the COVID status, Bhutan has also been affected like all the other countries in the world. As of today, Bhutan has reported about 861 cases and just one death. And the recovery rate has been 99%. And we have just 6 active cases as of now. And to tell you about how we were going about, the Bhutan reported its first case on 5th March 2020. And since 23rd of March, the international borders had been sealed, and it's still sealed. And Bhutan had 2 lockdowns. First lockdown was in August, and the second lockdown from 23rd December for almost 28 days. And now we have just opened up after this first thing. So to talk about how Bhutan managed the COVID and the best practices that helped us during the pandemic were that the most important thing was leadership at the highest level, from His Majesty the King himself leading and guiding us. He showed us the vision, how to go about. He said that there should be no deaths in the country. So that was a vision, very huge task to perform in that area. And he also informed the government to ensure food security during this pandemic and to ensure social security. So these were the 3 wisdom coming out from the king himself. And this brought all the forces in the country together under one umbrella to work towards the common vision. And the Prime Minister himself, as the chairman of the National COVID Task Force, brought the whole of the government approach to respond to this COVID. And the health minister herself was the chairman for the Health Emergency Management Committee and was leading the technical and health aspect of the response. And she was guided by the technical advisory group that was immediately formed before even the pandemic was declared. We had already formed a technical advisory group, and we had developed the National COVID Preparedness and Response Plan. And the technical advisory group for COVID was comprised of experts, not only from Ministry of Health, health experts, clinicians, but epidemiologists, and even experts from the animal health, because we had a very strong One Health network in the country. So that really helped us bring us all the experts together in one under one umbrella. Then the other aspect was the religious bodies were fully involved in the advocacy, and business communities, CSOs, and the communities and individuals all came out in very big way. And thus the whole of the society approach was really in action. The second one was that the command and control structures within the country was immediately set up to address the whole of the country approach. So in the central region, in the capital, there was a central COVID task force working directly under the National COVID Task Force chaired by the Prime Minister. Then in the eastern region of the country and the southern part of the country also, we had formed the COVID Task Force to give leadership and to guide the district level COVID Task Force. So these structures really helped us in moving forward in a big way. So what were our strategies? Our main strategies from the very beginning was test, trace, and treat. So Bhutan, we were very fortunate that Bhutan has a fully functional and equitable public health service system. And that is, and there's no private practice in the country. And we already have a very proactive disease surveillance and early warning system in the country. So as a result of that, we were able to detect suspected cases immediately and test them. We have a BSL-3 National Public Health Laboratory with well-trained staff in the good laboratory practices, biosecurity, and biosafety that enable there was disruption. Since we had a very well-trained set of staff in the public health laboratory, we were immediately able to set up overnight. People were sent over to all the important areas, and then we set up 5 more RT-PCR testing labs. We had only 1 in the beginning, so 5 RT-PCR testing sites were overnight built, and Bhutan also identified strategically located COVID treatment centers immediately. And we also planned our surge capacity in human resource, in our equipments, and in the beds and everything we were already planned. And we had a cadre of volunteers that is specially trained by His Majesty himself. We had about 15,000 volunteers. They are called DESUPs, and they were very helpful, and they were providing the essential services. And they were also initially we were manning the quarantine services by the health when the cases were less, but later on we shifted the task to those volunteers. We trained them, gave them safety training and how to don and off all these PPEs and all, and they were able to take over. The task was shifted to them, and they were manning the quarantine centers and all. And for all the people who were entering Bhutan, the quarantine was compulsory for 14 days initially, but we immediately changed to 21 days after we found that on the 15th day, some of the cases had come out positive. So we expanded our quarantine, compulsory quarantine for 21 days. And all these quarantine facilities are provided free of charge to every traveler, whether Bhutanese or expatriates or business people. Everybody was provided this free quarantine services. So as a result of that, we were able to test them in time. And if they came out positive, we were able to isolate them immediately in the COVID centers and release them only after testing them negative with RT-PCR. And then after that also, we were de-isolating them for another week and testing them and sending. As a result of that, we had, for quite some time, we did not have community transmission. We were able to withhold community transmission for quite some time. But then again, we had some community transmission sometime after August, and then we had to have a lockdown. The other thing that was very important was that there was so much information everywhere in the media and all. So the first thing we did was that we had a good media monitoring system put in place, and media and risk communication team was already there to look out for all the informations and all those things. And we decided to have only one source of information. The PMO's Prime Minister's Office and the Ministry of Health were the only ones providing them the authentic information. So there was press briefs almost every day when the cases were high. And then we depended a lot on ICT and digital technology, which was in the real sense used and during this outbreak. And then several apps for tracking and tracing and surveillance were developed during this time. And virtual and Zoom platforms were used like never before. And we had information for sharing information and to give information on the services and all. A lot of toll-free numbers were expanded, and we were providing them services through our hotlines and providing them guidance through the hotline. So hotlines were doubled, tripled, or even tenfold increase in the hotline numbers and all during the acute phase. Then to map out and zoning and risk profiling was done using GIS and mapping system. And what we did for the public health measures is that we intensified public health measures, and as soon as the outbreak was announced, a lot of hand sanitizers and all those were given, and hand washing stations in all the public places and in schools were instituted before the schools were opened. And it was not just temporary setup. From temporary to permanent ones we moved, so that it would remain even after the COVID pandemic passed by. Then the flu, we also established separate flu clinics in the country so that the cases do not mix. And these flu clinics, we overnight, within a week, we set about 54 flu clinics all across the country, and they were managing all the flu-like symptoms and doing the surveillance, and we were keeping track of community transmission. And we did not get community transmission for quite some time because these flu clinics were really well equipped and managed properly. We faced a few challenges, however, during our thing. The biggest challenge for the Ministry of Health is the human resource. In Bhutan, we have very limited numbers. We have only 376 doctors, barely 5 doctors per 10,000 population, and nurses is also 18 nurses per 10,000 population. And you can imagine the surge capacity, the human resource capacity that was there in the country was so limited. We have only one ICU specialist in the country. So we started with that, and then over the months till now, we have been able to train people, reskill the people who were retired were brought back, students, medical students, everybody was called back to the country, and they really were trained, fast track trainings and all those. And then we were able to manage the cases, and we were not so overwhelmed because of all these things that we have done. And the other challenge Bhutan really faced is that Bhutan heavily relies on import of medicinal products, equipments, even food supplies from outside the country. So we do not have a single manufacturing unit for pharmaceuticals and all. Therefore, we were really, yeah.
1 more minute.
Yes.
Okay.
So all these are some of the challenges that we have really faced. And the other thing is that closure of the borders, that every country was having this closure of borders and all those things. And Bhutan also had this issue. So I think by air or by sea, all these point of entries are really well managed, but ground crossings are something that we need to really look into and intensify, like in the Mekong Basin disease surveillance system. I think the ground crossings and the countries should have a lot of collaboration, coordination, information sharing, and a lot of human resource sharing can be done. So these are some of the things that challenges and the issues that we faced, and how we could contain our COVID response. Thank you.
Thank you so much, Dr. Nazeen. This is really very fascinating and interesting. I'm sure all the participants would have found it very interesting. I have to admit that I did not know about the experiences of Bhutan in tackling COVID-19 and the challenges that you have highlighted. I hope we do have the time to discuss how regional cooperation can help address some of those challenges. So thank you so much for a very fascinating talk. Let me now move on and invite Dr. Rumana Haq, who is a professor in the Department of Economics at Dhaka University, to share her views with the audience. Dr. Rumana Haq.
Thank you. First, I would like to thank the organizers for giving me the opportunity to say a few words in this very important webinar. I would like to emphasize on a few points that where I feel that the regional cooperation is really important and can benefit everyone living in this region in the health sector. And when saying so, I just want to highlight one point that sometimes when we talk about health, we focus more on clinical issues and more sort of curative care. But I would like to highlight that even we have to focus more on preventive care. And though the COVID has taught us that infectious diseases are so important, and we have to keep our eye on to manage COVID or many other infectious diseases. But despite that, we also have to remember that preventive cares and collaboration or learning from each other on that side is very important. So on that note, I would like to highlight a few issues that When we talk about health system, we have to look into all the building blocks of WHO, including governance, financing, service delivery, and drugs, and all, all sides. And when the cooperation comes, we should look into in all the building blocks that where we can cooperate with each other. So I will try to highlight a few issues. The human resource is definitely one of the most important building blocks, and how we can develop the capacity within this region. And when we say that capacity, it is not only the doctors, but also the lab technicians and community health workers. So how we can learn from each other and develop the capacity of all the frontline health workers and doctors and other health workforce, so that they can learn from each other and contribute in combating also COVID, infectious disease, and I will come to non-communicable disease in a minute. In terms of the drugs and other medical equipment, definitely we need cooperation, especially to regulate the pharmaceutical industries and also some other groups who are producing those medical equipments. So if we want to keep those affordable across this region, we need cooperation and we need policies so that we can regulate all these industries, staying on the same platform. So that is something I wanted to highlight. In terms of financing, definitely one of the questions is that how we can ensure sustainable financing. And this is the critical point, because though we say partnership, collaboration, strengthening relationship, but financing is very critical. And always we say in Bangladesh, taking the example of Bangladesh, is that health, though over time the absolute amount of resources allocated to the health sector has gone up, but in relative terms, in the national budget, health remained relatively neglected, and we always had to fight to prioritize the health sector in the national budget. So how we can mobilize additional resources so within the country, and also ensure the cooperation and collaboration within this region. And here we have to find out alternative financing mechanisms, and insurance has been identified before, with a special guest, and I really try to highlight that point, that maybe health insurance is one, but are our health system ready to go for health insurance? So there are lots of supply side issues that we need to take care of, and also the readiness of the demand side, also the clients, that are we ready for the health insurance? If so, what modalities we can implement in a country like Bangladesh. And there are other countries where they have introduced health insurance and they are implementing these efficiently, but there are some hiccups and there are some challenges they face. Even in India, there are multiple health insurance in a small bits and bits. Now they're facing the challenge that how they can come up with a holistic approach. Even in Thailand, they started health insurance with different groups, and at some point they felt that there are lots of smaller pilots or initiatives, but how to bring everyone under the same package, that they face that challenge. So definitely there are opportunities to learn from those experiences, so that when there are people going for cross-border and taking the health care, so they all are insured within the country, and even when they travel. There are other issues in terms of financing. When we look into the mobilizing the resources, definitely the GDP tax ratio in a country like Bangladesh is quite low, and tax coverage is also quite low. So we have to find out some other ways where we can mobilize resources. And one option is like to introduce or increase the sin tax. Like tobacco, I'm advocating for increasing the tobacco tax for long. So that has to be taken very, seriously. And also some other products like alcohol or sweet sugar beverages, junk foods, those can be brought under taxation, and we can mobilize these resources, and we can earmark this resource for health system strengthening. So those can be, there are lessons from other countries, and we can learn from there. When we talk about the clinical practice and cross-border health tourism, definitely there are something I would like to highlight, that many people travel from Bangladesh to neighboring countries for their treatment, and when they travel, definitely there are issues for that we can ease, and we can make sure that there are policies in place so that we can make things simpler, and at least when there is emergency, we can respond to those emergencies. So this became very apparent that during COVID, we could not even travel. People had lots of money, but what is the point of having those money if we can't use those when there is a need? So that also reminds that those who are, investing in trade and other issues, if they can at least invest some of the resources for developing the health sector, and we can develop the health sector within Bangladesh, and then strengthen the system, then we may not need to go abroad for treatment. So just to highlight that different countries have a comparative advantage on different issues. So if we can support each other for capacity development, that would be helpful, and not that will reduce some cost, or some resources, save some resources for some countries like Bangladesh, because we spend quite a lot of money on health tourism. On that note, the out-of-pocket expenditure is quite high in many of these countries, because government is spending less and people has to invest more from their own pocket. And I mentioned earlier the issue of insurance. So we really have to think that how we can encourage government to invest more on health, and especially on the preventive care, and learn from each other that what are the base case studies available. I would like to highlight just very briefly, please let me know when my time is over. Bangladesh used community clinics and community health workers, frontline health workers in multiple ways, and we found it was a successful model for Bangladesh. Even for the TB control program, immunization, we used the frontline health workers, family planning really well. But during COVID-19, we could not use them as expected. So we have some some areas where we can share the learning, but maybe some other areas where other countries have experience. Especially during the COVID, they could use or mobilize some of their resources more efficiently than some other countries. So how to share those experiences? I think that was one of the issues raised during these webinar or through these workshops for the last couple of days. So there are some networks already available. I will give an example from my experience of working in tobacco control. We have smokeless tobacco control knowledge hub based in India, but many other countries are members of that. So we, through that network, we are generating evidence, we are sharing those, and we are applying for funding for research and also for implementation. There is another network already mentioned, one of the speakers, that One Health group. They are working in Bangladesh also on antimicrobial resistance, and that network is very effective, and they are very good in generating evidence and also influencing policy and practice. So how we can form this type of networks where we can mobilize all the partners and can share the lessons. And also it's not only sharing lessons, also trying to influence policy and practice. So these networks can really be helpful. Just the last point is when we talk about this type of partnership, collaboration, definitely we want equitable partnership. So from the very beginning, how we can ensure that equitable partnership so that the capacity development and other issues that we are discussing are balanced and everybody feel trusted and feel that this network or partnership is beneficial for everyone. So I'm sure on that note, I will stop there. That I hope there will be opportunities to leverage of the learning that we had during COVID or even before COVID, and there will be regular communication within these groups so that we can learn from each other and we can implement what we have learned, and there will be adequate resources to sustain these initiatives so that we can achieve what we proposed or agreed for sustainable development goals. So thank you.
Thank you so much, Professor. Thank you so much for raising a number of very relevant points. I think I completely agree with you that we need to, it's one of the options that we can use the WHO's, health system building blocks as the conceptual framework to discuss, the issues of regional cooperation. And thank you for highlighting the issue of financing. But I think also we also need to, you also, raised the issue of efficiency. I think efficiency is also something that we need to look into in terms of the various building blocks, in terms of, health information systems, in terms of governance and, manpower, etc. So I think definitely there is enormous scope to, raise financing for the health sector. But at the same time, efficiency is also something that, we also need to discuss in terms of regional cooperation. So thank you once again, for raising a number of very relevant issues. So may I now move on to the next speaker, invite Dr. Reji K. Joseph, an associate professor at the Institute for Studies in Industrial Development, ISID in New Delhi. Dr. Joseph.
Thank you, Dr.
Yeah,
Maxine.
so 7 to 8 minutes.
Yes, that is
sure. Great. Thank you so much. Thanks.
Thank you. And thanks to the organizers for inviting me to speak in this panel. COVID-19 has given us an opportunity to realize the need for global cooperation in handling pandemics of this magnitude. Apart from personal sufferings, the COVID-19 has also resulted in decline in economic growth. So this made COVID vaccines as a sure bet for the economic recovery. So in the attempt to revive growth, a few countries tried to amass the bulk of global supply of vaccines, which squeezed a large share of global population from accessing vaccines. So in this context, the approach that India has taken in sharing its vaccine capacity with its neighboring countries and other poor countries has gained global attention and reinforced the realization that global cooperation is very much essential. So I would say that the global cooperation has to go much beyond COVID. So we have a unique set of health challenges that calls for at least the regional cooperation in the health sector. See, as we know, the BIMSTEC region is one of the worst affected in terms of neglected diseases, in some neglected diseases. For example, lymphatic filariasis, nearly 2/3 of the global disease is prevalent in this region. 1/4 of TB is occurring in India alone. And similarly, the climate change induced infections. So this region is very prone to such infectious diseases. So we have a set of unique challenges that we can address collectively. So I have identified 3 specific areas in which we can cooperate. So before coming to that point, I would like to show you some scenarios which is common to all the countries in this region. I have a presentation, I will share it now. Yeah, see, if we take the healthcare expenditure in most of the countries except Bhutan and Thailand, majority of the health expenditure is met by individuals' own financing. It is out-of-pocket expenditure. It is as high as 74% in Bangladesh, 76% in Myanmar. So this means that affordability of medical products is a major concern prevailing in most of the countries in this region. If a medicine or a vaccine, if it is unaffordable, then the effectiveness of healthcare services will be adversely affected. So this is one set of challenges facing this region. The another one, look at the R&D expenditure. The countries in this region spend less than 1% of their GDP in R&D. This is overall R&D. It may be possible that some countries spending a higher share in certain sectors. For example, in pharmaceuticals, India is comparatively performing better in R&D. But generally, the technological activities are very, less in this region. So then, from where are we expecting the solutions to come from? If there is a disease, if there is a problem, there has to be some solution. Who will provide the solution? And our requirement is that such solutions should be affordable. Because the healthcare financing is, much of it is from out of pocket. expenditure. So the solutions that are coming up should be affordable to our population. So in this background, I have 3 sets of proposals. Let me slightly arrange the screen. Yeah. One is alternate models of innovation. The innovation model prevailing globally, that is based on intellectual property rights protection and monopoly pricing. So the intellectual property rights are given to innovators as an incentive for innovation, and they are allowed to charge any price. As a result, what is happening is that the innovators charge exorbitant prices, which results in limited access. Only a few people are able to afford those products. And this model has been proved to be counterproductive, because the innovators, since they are allowed to charge any price, any profit they're allowed to make, there is no compulsion for them to bring in cost effectiveness in the innovation process or bring in more efficiency in the innovation process. As a result, what has happened over the time is that the number of new chemical entities developed has declined over the period of years. And this model is also not taking care of some issues prevailing in the developing countries, like neglected diseases. No company is interested in developing new drugs for treating such diseases. So this model may not solve our problems. So we need to find alternate models for innovation. So here I would suggest we should identify certain therapeutic areas or diseases where we can pool resources for conducting R&D. And we can synergize the expertise that we have developed in doing R&D more cost effectively. I will give one example. The Cadila from India, it developed a new chemical entity at a cost of $250 million US, whereas the average cost of developing a new drug globally is reported to be 3 billion. It's not million, 3 billion. So less than 1/10 of the cost the Indian firm was able to develop a new chemical entity. We can say it is partly because of the lower cost of doing R&D, but that alone will not explain this one. This is also because the cost effectiveness that the company was able to build into its R&D process. So we can learn from such expertise that we have in this region. And we also have models like open source drug discovery, which we can use in developing new solutions for the healthcare challenges that we face. So this is one area where we can cooperate. Second is collaborative research projects. The Department of Science and Technology of Government of India has a scheme for funding international collaborative science and technology projects. I was looking into the annual reports for the past few years, and I find that except last year, we don't have any collaborative projects with any countries in the region. Last year, we have 12 projects out of more than 300 projects. That's from Sri Lanka, and that's mostly in the sector of renewable energy, and no projects in the healthcare sector. And nearly about 9-10 years back, we had conducted a study, so myself and the Professor T.C. James were part of that. So that time also we found that collaborative research activities is it was not existing in this region. And we interacted with a few people and find out why such projects are not taking place. The response we got was that there is a gap in the level of understanding of people in different countries in this region. So, and there is also communication gap. So what I feel is that if we have to address the healthcare challenges, we should be able to promote collaborative research projects. For that, we should have what to say, a certain level of human resource development. For that, we can have exchange programs. The faculty from universities can be exchanged, and the scientists from research institutions can be exchanged. So this will be one way for developing human capital in this region, which can facilitate collaborative research projects. Third one is enabling an environment for the adoption of new technologies. If we look at the development of vaccines for COVID, in about 1 year time, less than 1 year time, we were able to come up with some vaccines. Conventionally, it used to take about 10, 12 years. Yes, we have fastened the steps involved. Even then, the new technologies also played an important role. New technologies like genetics, artificial intelligence. So all such technologies have helped in reducing the time in coming out with new technological solutions. And we have number of startups specializing in different areas of healthcare services, like diagnosis, treatment, development of medicines, management of treatment, medical devices, so on and so forth. But
Joseph, one more minute.
Yes, I'm going to finish. But what is essential to these technologies is the big data. So big data is essential for development of such technologies, and we need to have proper regulations in place to ensure that the privacy of individuals is not compromised, and at the same time, the data is made available to the enterprises for innovation. So this is a very balancing act that we need to do, and India is in the face of began the activities for enacting such a legislation. But as a region, in the long run, if we have to benefit from the new technologies, we will have to create an enabling environment, and this regulatory system is very important. So this is my third proposal, creating an enabling environment in this region for the adoption of new technologies. Thank you.
Thank you so much, Dr. Joseph, for sharing your views and very concrete proposals on which regional cooperation can occur. Thank you so much. I think one of the issues that we also need to discuss is the efficiency of drug regulatory cooperation and the efficiency of drug regulatory authorities in the region also. I think that is also something that we can discuss, and also how they can cooperate. 3 years back, we did a report on international cooperation for the registration of medicines. I have shared it in the chat. Although it was not in the context of COVID-19, but it might be relevant at the regional level also, and also in the given circumstances. So thank you so much for your excellent and very pointed, focused interventions. May I now move on to the next speaker? Invite Dr. Samir Dixit, the co-founder and director of research at the Center for Molecular Dynamics, Nepal, to share his views briefly. Dr. Dixit.
Hi, so good evening, everybody. I hope it's good evening where you are. I'm assuming everyone is in our region, but for everyone who's not, good afternoon, good morning, whatever it is. Wonderful to be here. Thank you very much for inviting me. It's an honor to be sharing the platform with such a knowledgeable and expert group of panelists and speakers, obviously. So I thought I would kind of share in very briefly, as you mentioned, what our experience has been from Nepal in terms of public health and in collaboration and surveillance activities, and where we may need to put more attention as far as it comes to the BIMSTEC regional collaboration or working together modality. Now, I just while I was listening to all the previous speakers, I was quite taken. It was very interesting to listen to Professor Chaudhary's experience in working with the other network, which obviously Nepal is not part of, the Mekong. But I was wondering why to this day, in the context of COVID, that we still don't have a proper disease surveillance network that comprises of South Asian countries and also the Southeast Asian countries, which BIMSTEC obviously has included in its network. Now we might say WHO is there, now, but then the WHO, like for example, WHO CRO region looks after a lot of these countries. But then there's something beyond just WHO. There's the research side of things also. It's not just surveillance only. So when we talk about surveillance, there's always that research that always and almost always comes together. Every time we say surveillance, the research part cannot be left behind. And in most cases, we forget that there's a research part there also. Now, why can we not start thinking of a research and surveillance network? Now, I know from previous speakers, funding is always going to be a problem. And that's a perennial problem. It's not just for South Asian countries, it's not just for developing countries. Even developed countries have these issues with funding. And that's something we have to work together to identify how we go about it. But if we get it started, at least we can start thinking about the funding part later. First of all, I think what we need to see is, why did COVID happen? And for example, when you say COVID happened because of the SARS-CoV-2 virus, that started from, let's say, Wuhan, China, and then it kind of spread around the world. In this world of technology and in a high-tech surveillance methodologies available worldwide, how did COVID become COVID? I mean, if you think about it, if you go back, the very obvious answer is we obviously haven't been working together as well as we thought we were. It should have never gone out of control as it did. Now, we cannot control the world. We cannot control what goes on in all parts of the globe. But at least we can control, or at least we can try to control what happens on our part of the woods. And we have similarities in the genetics of our population, our lifestyle, even the climate and weather. There are a lot of similarities. I know there are differences, but there are similarities also. So if we were to develop a network of disease surveillance and research, something like, let's say, SARS-CoV-2 infection, or could be CoV-3, CoV-4, or some other influenza, anything, could be controlled at least on our part of the woods before it goes out of control. And speaking of which, now when I say research, one example, like the previous speakers, like from Bhutan, also from even other countries in this region, we noticed that this part of the world, especially in BIMSTEC countries, South Asia, for example, and Southeast Asia, the mortality and morbidity has been quite low compared to Europe and America, even Latin America. We should start thinking why. If we had a genome database of our population, if we knew a bit more about how this disease was affecting our population in a package, in a very holistic way, maybe we would have started coming up with answers already. Right now, none of the countries in this region can say what is going on. I mean, what's happening in Europe and America? Why is it not happening in our part of the woods? Do we have a prior, let's say, cross protection? Do we have some sort of enhanced immunity? Is just we as South Asians or South Asians have some sort of a different way of dealing with the virus? That kind of question should be able to be answered by the community in these countries. And that may give us an edge to understand diseases from another angle, which normally, like let's say the West, may not be seeing. And I'm just giving you examples of things of the kind of questions we can ask each other and the world, where regional cooperation, especially in the BIMSTEC region, can answer. Now, we talk about public health, we talk about One Health. There are One Health networks. I know there are public health networks in each country, but we are not working together. And it's about time we started working together. That's why I'm so happy that we have this discussion going on today. That is there a way? Are we ready? Are we in a position to get this surveillance network, research network started? Could be One Health, could be public health, could be combined. And for too long, we're too focused on the type of public health, One Health, biomedical. This kind of work should not matter. We could be combining overall disease. Let's understand the disease. And I know I don't have much time, so this is an idea I thought I could share with you today. And as regards this vaccine, I wanted to, because this panel includes people, experts who have worked on vaccines, who are economists. I can see there are a lot of economists, health economists in this group also. We have this for the immediate, when I say immediate collaboration, we have this COVAX network, right? I'm sure you're aware of that. WHO, UNICEF, Gavi, coming together with 92 countries, including a lot of the countries in this region, and providing vaccines for the region for immediate use, in the next 2-3 months. Wouldn't it be nice? Wouldn't it be nice if these countries had already come together and started working on own vaccine development? When you have your own, like I know India makes its own vaccine, maybe some other countries are maybe thinking of making vaccines, but why can't we have a combined regional vaccine development authority or organizations that work for the not just for the country but for the region? So then, while you were waiting for a big structure like COVAX, we could have been working together as a regional power and vaccinate the people in this region like Europe is doing through AstraZeneca, for example. So that's another area where I think we should work is R&D. And that's an area where I think a lot of effort needs to be required. And I think there's expertise there, especially with India there and Thailand there. I mean, India has a very strong presence in not only this region, but also the world. So that expertise can be utilized. And for public health, Thailand as well, probably the best public health structure in the globe. They're very well respected. So if we would combine these two, these are the areas, the immediate and the long-term areas I think we should go towards. And lastly, because again, I could go on and on, but this is an area where, as a panelist, I just want to drop on what other people have said in this panel and what we can further take forward. And lastly, I just want to touch up on the funding. I know the economists here have already given the very good ideas. Now, funding is always difficult. I mean, we know that. I already mentioned that. But then, what if we were to have the leaders of each government, our government leadership, put in, you pitch in funding, then you ask for a matching fund, we look for a matching fund, for example, could be Gates Foundation or USA, DFID, our international partners who have for a long time supported, this part of the world also. I'm not saying we go begging, but at least if our government chips in and then we ask for the matching funds, this could be a very good way to move forward. So with this, they are doable things. And from Nepal, obviously we have expertise, and that expertise in both public health and R&D, and there's a big knowledge base in health. We could also chip in with our expertise and interested in population, also very talented scientists and researchers. So with this, I would like to stop here so that I can listen to more of the panelists and then have an active discussion. Thank you very much.
Thank you so much, Dr. Dixit, for sharing your insights. This is really helpful. I remember when we released our report on international cooperation for registration of medicines, one of the points that the drug regulator pointed out was that there's so much fragmentation within the countries also. So if, for instance, if you look at India, there is so much fragmentation within the health system in the country itself. So he suggested that we also should work for cooperation within the countries before we go out, and talk about regional or, global cooperation. So I think addressing the contradictions and, the fragmentation within health systems within the specific countries is also something that we need to think about. Secondly, we also, I think, need to look at the political economy aspects of, research and surveillance. I mean, we have had, the international health regulations 2005, but why do countries, hesitate to, inform the WHO under IHR 2005? So there are, so I think we also need to make an effort to somehow de-link, health from political economy considerations. And with that, let me invite my last speaker, Dr. Shani Dabrera, because I think my impression is that in Sri Lanka has somehow been able to de-link, and have continuity in the health sector, irrespective of, the political dispensation there in the country. So, Sri Lanka has had very exceptional, health achievements for a very long time. And, we are really eager to hear from you, Dr. Dabrera. So over to you.
Good evening, Honorable Chair, distinguished panelists, and participants. Thank you very much for the opportunity given to interact with this esteemed audience and share the Sri Lankan experience with our regional allies. I will be focusing on the country's response to COVID-19 pandemic and the opportunity for regional advancement in the post-COVID-19 period. As you all know, Sri Lanka is a lower middle income country, and as Ali correctly said, it has a past history where the health indicators are the best among the other nations in South Asia, and quite good from an international perspective. We have a population of around 22 million, and the literacy rate is high. And the COVID pandemic has made an unprecedented threat on both the health status and the smooth functioning of the economies in the world. And Sri Lanka is no exception. We started the preparation for the pandemic way back in January 2020, way before the world started their preparations, because we had Chinese engineers straight from Wuhan who were working on various projects around in Sri Lanka, and they returned to the country when the COVID-19 was spreading in China. And our health authorities, although we didn't know that it could accelerate to a pandemic at that time, prepared the institutions for the outbreak, because we had several Chinese tourist groups and Chinese workers, and we readied the laboratory and preventive surveillance in the country. And thanks to the advanced preparation for a pandemic from 2005, back when the avian influenza, SARS, MERS, everything was rampant in the world, Sri Lanka had lab facilities to detect the virus early. And in terms of disease control, we managed the pandemic successfully by very early case detection, identification of the contacts, quarantine, travel restriction, and isolation. Sri Lanka reported the first case in a Chinese tourist on 27 January 2020. We detected the patient in our own laboratory, and subsequently in a local person on 11th March 2020. During the first wave, there were 2,810 cases up to July, and there was a period when we did not have any community case, a cluster in the country. And the second wave started in October in the apparel industry, and we had increase in numbers until then. As for today, the cases stands at 71,211, and we have recorded 370 deaths from the first wave. The healthcare system in Sri Lanka is actually a world-famous system which is delivered through two discrete services, one curative and preventive. Both are free. And the curative care services are based in the hospitals, which range from National Hospital of Sri Lanka to the primary medical care units, where only the outpatient department functions and the patients are given walk-in medicines. And the preventive health services are mainly provided through healthcare units, known as the MOH areas. So when we actually dealt with the COVID-19 pandemic, those medical officers of health areas came into the forefront. This is the cornerstone of our disease prevention activity success story. And the 100-year-old Quarantine and Prevention of Diseases Ordinance was activated to control the pandemic, and the medical officers of health were empowered to exercise this ordinance. And the entry of the virus to the country was stopped by closure of the airport and the ports, and being an island, it helped in the first wave. And extensive tracing was done of the recent returnees from overseas. And the identified patients were transferred to the designated hospitals, and potential contacts to more than 40 quarantine centers. They were developed within a very short period with the support of the armed forces. In addition, the government began repatriating citizens stranded abroad and quarantined them for the 2-week time period. And the masks were made mandatory in indoor and outdoor public spaces and public transport, and still it is being practiced. The police and the army have been empowered to monitor the situation, and the sanitary measures such as having wash basins and sanitizers outside the stores, public places, supermarkets, schools, workplaces, and other industries have been initiated. Schools and the universities started online teaching, and other technology was used. The impact of the ongoing pandemic affected and further worsened the livelihood of individuals and families in the country. But up to now, Sri Lanka, the government provides free testing, free hospital care, relief measures, and free transport, and free quarantine facilities for repatriates and all their citizens. Of course, there is a option for private health care if one wishes, but the majority of the health care provided for the COVID-19 as well as other medical needs is free. The firm and committed political leadership, a task force was appointed and monitored, and foreseeing the future risk and advanced preparation, timely decision making, regular communication with all the sectors, and intersectoral collaboration with the support of the other agencies, the CBOs, and the other NGOs, resulted in good public health response and the successful control of COVID-19 in Sri Lanka. The coronavirus actually dealing the so-called globalized world village into isolated entities. And even the next door neighbors were physically disconnected from each other. The impact of the ongoing pandemic severely affected the livelihood of individuals and families, with the enforcement of continued island-wide curfew in the first wave, cross-border mobility, restriction, lockdowns of the country and regulations, and other precautions. Sri Lanka, which had a very vibrant tourism industry and a good economic center in the apparel sector, and small scale industries are all affected. However, the resilience of the society with the involvement of the community has shown results to overcome the economic impact. The human capital remains the real wealth and the capital in Sri Lanka, and it is the strength of our Southeast Asian region as well. Our region, actually, with the entry of the vaccine as a control measure in COVID-19 pandemic, our region came into the forefront as India is identified as one of the world's largest manufacturers of the vaccines. And our region benefited by the availability of affordable vaccines from India. And the regional cooperation is needed to ensure equity in vaccine distribution. And there are opportunities for a green recovery of our region. As we all know, our countries are blessed with clean water, greenery, and Sri Lanka in particular has a very fertile soil where we can grow anything. And I think all the other countries in our region are very, very fortunate in having a temperate climate. So we are sort of, we can be self-sufficient if we have the power to do that, and to enhance the sustainability of the country's abundant natural resources in the land, forests, wildlife, and oceans, and to push ahead with cleaner energy and green infrastructure. The use of technology, as never before, the disease surveillance was enhanced. Activities, those were actually facilitated by the use of technology, but for monitoring, surveillance, contact tracing, and testing, and even clinical management of those patients. So as we all know, COVID-19, the disease itself made a sort of a stigma and fear among the health staff. So when we started building the hospitals to isolate and treat those patients, technology was used to communicate with the people, with the patients. So we were fortunate to get the technology from the other countries. We got the support from WHO, and we used our very own resources to manage the patients while communicating with them. And through those technological advances, we were able to actually curb the transmission from the patients to the healthcare staff. So unlike in the Western countries, our healthcare staff in Sri Lanka were not like were not affected by the COVID-19 virus. And so far, we have only one death of a very young doctor who was having comorbidities, and a very limited number of healthcare workers affected by the COVID-19. And they were like, they protected the community and prevented community transmission of the virus. The technology actually helped a lot, and the communication, because the world became so isolated with, even though we were an island nation, we were having a very vibrant tourism, tourist industry with border crossings and trades. So this actually stopped for the past 1 year. But through the use of technology, the regional cooperation should be strengthened. So I'm really glad to have this opportunity to listen to the distinguished panelists. And I was so happy to hear about the Bhutan experience, because it shows the how COVID-19 accelerated the development of the health system in our countries. And this is our story from Sri Lanka. And we have actually, as distinguished speaker pointed out earlier, our region, we have to study what is happening, why we have successfully curbed the transmission, if there is any reason for the reduced morbidity and mortality, and if there is a place for immunization and vaccination, and whether the history of BCG, having BCG vaccination with a high number of recipients. We have 100% coverage with the BCG vaccine. We have to do some research to find out where all this leads to, and whether this plays a role in the disease transmission, and to find out whether this is actually beneficial for the next pandemic or the outbreak which can occur in the future as well. Thank you very much. And again, thank you very much for giving me this opportunity.
Thank you so much, Dr. Dabrira, for sharing the Sri Lankan experience and highlighting the actual and the potential role of technology in dealing with such pandemics. So now let me finally thank all the distinguished speakers who have shared their views with us. And it's time to move on to comments and suggestions. So I see already some comments and also some questions in the chat box. So let me start with the first comment, which I would like to convert into a question for Dr. Mushtaq Chaudhry. Dr. Chaudhry, are you there?
Yes, I'm here.
Okay, so there is a comment actually here in the chat section saying the Mekong Basin disease surveillance is a wonderful example that can be emulated in BIMSTEC countries. So let me formulate this into a question. So do you think this is possible, and what are the potential challenges in doing so? So can you quickly share your views on this?
Sure. Thank you. Thank you for this opportunity again. And I think it's definitely possible, although there will be a lot of challenges, as you all know. But in the MBDS countries, it's not that all the countries are friendly to each other. There are problems there, but even then, they have been able to really come together and do that. So, in order to do this in the BIMSTEC countries, I think it's first of all it's important that there is a kind of an inter-country agreement that this is something that needs to be done. And this can be done through a kind of a meeting of the willing or the converts to see whether such a thing is possible. And I remember there was a meeting actually in 2014 in Kathmandu at the SAARC headquarters, in which they tried to start something for South Asia. But unfortunately, it didn't move further. The simple reason why it didn't move was that the SAARC is a kind of a morbid institution. So they cannot do that. So we have to really find some sort of a forum or an institution which can actually steer it. And so it's important, but it can start with even a small number of countries, even two countries. If two countries sort of agree to do it, they can start a kind of a surveillance between them. And then other countries, by seeing this as an example, can also join later on. But it doesn't have to be that all the BIMSTEC countries have to join together at the same time. We can start small and then move forward. Thank you.
Thank you so much, Dr. Chaudhary, for your comments. So then there is another comment in the chat section with several questions. So I mean, any speaker who would like to respond. So the first question here is, any good mathematical model which could predict COVID spread? And then, can deep learning models be used for predictions? Why was COVID negatively related with poverty, undernourishment, and rural population? So this is, these are a set of 3 questions in one comment. Would anybody like to respond to any of these questions?
Can I respond to the third question?
Yeah, sure, sir. Please.
I don't know, because the mathematical models I have been criticizing, they have all failed so far.
Yeah.
So far as the third one is concerned, recently 2 studies have come out. One, a domestic study within India, all the states covered. Another one was an international study covering 106 nations. What they pointed out is this thing, essentially about where there is no high-level healthcare, the COVID situation is much better. Now, the point towards which the researchers were pointing out was that maybe the natural immunity systems have gone down in the developed countries because of high use of medicines and vaccines and other things. That's all I can say just now, because this is a matter still out, a lot more research will have to be done. Thank you.
Thank you. Thank you, Professor. There's another question for you, Professor James. It says traditional medicine network in Bay of Bengal region is already there. How can that be reactivated as health challenges have multiplied heavily in the post-COVID period?
Yeah, I already put my reply to that thing. Actually, this has been there for quite long, and Thailand is the lead. But unfortunately, the thing is not making any move. That's the what I can think is, number one, even for traditional medicine, when you are talking about what exactly is the data we are having, and unless that data collection, sanitization, and all that is done at national levels, and then get into a kind of memorandum of understanding for sharing the same, because sharing of the data is going to be a big issue for the political leaderships everywhere. So that is where, in fact, for the surveillance system also, that is the major issue, because India has a very integrated disease surveillance system, but somehow it is not making its move to have a kind of agreement. And I, of course, agree that maybe, as Dr. Mushtaq mentioned, maybe 2 countries can start with it, but somehow this is a major problem. The second thing about traditional medicine, it is not something to be looked exactly like Western medicine, because the whole thing, these 2 systems operate totally different way. It is not a disease specific system. If some people make claims, they are essentially false claims, mostly about developing the immunity system within the body and a total immunity system. That's where, so unless we realize the reality of what the system is, how it is there, it's not going to be, effective at all. Third thing, there's again a lot of quality control and standardization which is required in traditional medicine, and countries will have to have again a lot of memorandum of understanding about how to harmonize the regulatory systems. So these are the 3, and this applies to the modern medical systems also. If we are to have common research and common surveillance, we need to harmonize our regulatory systems. Again, that's going to be a long task. So, because I have been with these people for quite long, I know how the government systems work. That's why. So, thank you. But it's a good move. We can start with it. I agree with the suggestion. Maybe 2 countries can make a beginning, and somebody can join later like that. That will be a good thing. Thank you.
Thank you. I think I like the term, which is integrated medicine, integrative systems of medicine, because I think right now what is happening is that integration is happening at the level of patients. So they are deciding which systems to go to, and we don't know the drug interactions and other things. There are several issues. Dr. Joseph, would you like to address the issue of traditional medicines from an R&D perspective? Because the issues of quality, safety, and efficacy are very serious. There are concerns around traditional medicines vis-a-vis safety, quality, and efficacy. So would you like to share your insights on traditional medicines from the perspective of R&D? Oh, you are on mute. You're on mute right now.
See, I am not competent in answering that question.
No problem. So then there is another set of questions. It says that collaborative research project is a brilliant idea. Can we draw a regional research program for Bay of Bengal? Who will fund it? Will it be G2G or B2B type? And this is a question which is specifically to Dr. Reji.
Yeah. See, I don't think it is going to be B2B, at least in the initial stage. It has to be government to government. So what I feel is that, see, if you look at this vaccine distribution by India, to neighboring countries, the vaccines were supplied on grant mode. And if you look at the grant distribution of India, this region is the largest recipient of grants provided by India. So one way could be allocating a portion of that grant, which forms the development partnership projects of India. A part of that can be allocated for these collaborative projects. That could be one way of finding resources for that. Otherwise, the countries can come together and pool some resources. That is another way of funding this scheme. But if there is a will, there will be many ways will open up.
Okay, great. Thank you. Thank you so much. So there is another question specific for Dr. Rumana Haq. It says, how can Bangladesh tackle the human resources for health-related issues that have been chronic in the country with regional cooperation? And as you mentioned, that medical tourism exists in this region. What are the lessons, solutions that can be replicated in Bangladesh? Dr. Haq, would you like to respond to this question?
Thank you. So what I meant is that when we talk about, human resource for health, most of the times the focus is on doctors and nurses, but there are during the COVID, we realized that due to the unavailability of trained medical technologies, we could not open up the testing at the early stage of the COVID. Then definitely we have to look into the other health workforce that is complementary to the entire health system. Having said that, in a country like Bangladesh, where doctor-nurse ratio is the reverse, the standard is at least one doctor should have, 6 nurses to support him. If not, at least 3 nurses. Where our is we have more doctors and less nurses. So how we develop the capacity of nurses, and there are many issues like when we talk about some service delivery, some of these can be delegated to the nurses or midwives, where we don't need maybe the doctor's support. So in this developing the capacity of human resources, if there are possibility of cross-country training, capacity development, that would be helpful. And also that we have to acknowledge that India has advanced in many of the health service delivery, where they are using sophisticated methods, and also some surgery and other areas we consider India to be like a pioneer in many cases. And also Bangladesh is also doing well, and maybe there are countries who are doing compared to like India or Bangladesh doing better, or maybe lagging behind. So if this type of cooperation, collaboration for training, capacity development can be initiated at the national level, it's going on, but we can consider these so that tourism or health tourism can go down. One point I wanted to highlight is that from Bangladesh perspective, we spend quite a lot of money for seeking care from abroad, not only India, but Thailand, Singapore, and many other countries. So that raises the question, why are not we investing within the country and taking the opportunity of creating capacity? And definitely research is one area. Other colleagues mentioned from Nepal that the research infrastructure, having huge research infrastructure, we are not using this platform to initiate. Even for the COVID, drug trial, Bangladesh could have been a part of that, and that requires lots of support from the governments of all these countries. Just one example, for medical research, we sometimes need to use biomarker. It is not only the survey that works, so you have to maybe test saliva, you have to use like checking indoor air quality using some equipment. But when we try to ship these or even import some of these equipments, we have to pay tax, and the policies are not in favor of doing all this kind of research and trial. So definitely I would like to highlight as I got the opportunity to invest more on the research, so that the HR or even I thank Professor Mushtaq Reza Chaudhary for raising the surveillance system, so important. So we need to invest on these, and that will definitely reduce the health tourism. Maybe it is good for some other countries to bag on that and generate revenue, but for some countries it's not affordable. So where if we can subsidize or create some sort of synergy, so that, as I mentioned, some sort of equitable partnership can be ensured. And I'm sure if we invest more on research and capacity development, that will take some of these, and and surveillance of all these is really important. Thank you.
Thank you very much. So there is a comment actually. I can't see a question here, but this is directed to Professor James. It says traditional medicines could not become an alternative system during the COVID-19 pandemic. A maze of prescriptions have been suggested, but they could not live up to the expectations of the needy. In the absence of R&D in traditional medicine, the efficacy of the traditional drugs are of no significance in treating the diseases. So there is a comment, but I can't see a question here, but this is directed to Professor James. Would you like to comment on this?
I have already commented on the same thing, but these are totally different systems. The Ayurvedic or other systems of traditional medicine, they are not disease specific. There was no COVID-19 on the past, and suddenly people claiming this is for that. It is all bogus, and actually within India, it really attracts the magical diseases remedies act even. But people could keep on claiming those things. What's required is they should also be brought strictly control these things. All that, just now there are clinical trials, and in Ayurveda, all that they can come out really is about the safety of taking a particular those things. And third thing is, a lot of people just assume that they don't require any prescription, they can go on taking. They have come across a lot of cases where people just over the counter, they purchase the things, take it for inordinately long period and create side effects, because Ayurvedic or Siddha medicines also have side effects if you don't take it under proper conditions. That's all I can just now say, not more on that matter.
Very true, very true. I think, I mean, what we talk about in terms of antimicrobial resistance is also relevant here, that, I mean, there is a specific period for which you need to take these medicines. You know, you cannot keep taking them, you know, forever. So they have side effects. And I think, so we did a report on traditional medicine, and even the practitioners of alternative medicine say the same thing. You cannot just keep taking them forever, you know, they have side effects. And so people need to be cautious about them as they are about, you know, antimicrobials. So there is a specific question for Dr. Dabrera. It says, is Sri Lanka ready to receive vaccines from COVAX or Sinovac? Dr. Dabrera, would you like to respond?
Yes, actually, we are ready and we have been waiting eagerly to receive the vaccines. So we received the first free vaccine consignment from India, and I'm already vaccinated with the first dose. And the healthcare workers and the frontline workers got the first vaccine stock. And we are now waiting, and we are being like ready for the past 1 month. We have identified the recipients. We have identified the vaccine centers. We have readied the emergency equipment and the other equipment for all the vaccination. And we have a ready-made health force, because we are vaccinating our children. We are giving all the immunizations through the public health system, through the public health midwives. So we have a very extensive network. Every third village will have a public health midwife. For every 3,000 population, the midwife will be there, and the public health inspectors are there, plus the curative care nurses and the doctors are ready for the vaccine delivery. So as soon as we get the vaccine, we are ready to roll it out. Thank you.
Thank you so much. Thank you so much, Dr. Dabrera. There are no more comments and suggestions in the chat box, at least. So may I now use my privilege and ask a very general question to, you know, all the speakers. One of the slogans of the present Italian presidency of the G20 is rebuilding differently. So we have seen that, you know, some of the most advanced health systems in the world have been, you know, devastated by the COVID-19 pandemic. Europe, US, I mean, they had excellent systems in place. They were, you know, really badly affected by this COVID-19 pandemic. So there is a worldwide need, you know, there is the recognition that we need to rebuild differently. So what is the role that, you know, countries in the region can play in developing a very different model going ahead, you know, to rebuild differently from the COVID-19 pandemic, and also be prepared for future pandemics if they were to strike the region? So any thoughts or ideas on this would be really appreciated.
May I?
Please, Professor Dr. Chaudhary, please go ahead.
Thank you, Professor Mehdi. I think, I mean, that there are many ways that we can really make best out of this crisis, and we have seen how countries in Europe, for example, or even Rwanda after the genocide, they build their health system. So we in the region must make sort of take this opportunity to build our health system in the way that we want. And there are ways that we can learn from each other within the region. So if we take the case of Thailand, for example, which has done so well, and a country like Bangladesh can learn a lot from Thailand and try to sort of emulate their experiences in rebuilding our own health system. And a few things that Thailand has done is that they have ensured community participation. They have those, the National Health Assembly and the National Health Commission, who sort of make sure that the community is represented in the decision that is related to their health. So that's one thing that they have done very well. They have also started universal health coverage. And you don't need a single baht now in order to do a heart surgery in Thailand, for example. And they have done it. And that has been possible because the government and the leadership there, they wanted to do it. And they have also invested on health. I mean, when Bangladesh, we spent less than 1% of our GDP in health, Thailand spends more than 3% of its GDP on health. So in order to do better, do new things, do sort of innovative things, we need money. And the government must come forward to really provide that money. So there are a lot of things that we can learn from our neighbors within the region, and we should really sort of seize this opportunity of the COVID to implement that. Thank you.
Thank you. Thank you, Dr. Chaudhary, very much. I appreciate your response, and I really agree with you. Anybody else would like to share any idea?
Yeah, if I may add something.
Yeah, sure.
So from Nepal experience, one thing we realized was that the role of surveillance again, because nobody thought that it would be so important. Now, when you look at COVID and go back one year, if you go back same time last year, nobody would have thought that what was about to transpire, what was about to happen, right? That's why this surveillance and this technology, taking in technology, a simple thing as a PCR, simple lab that can do a real-time PCR, we never thought it was going to be so important. We all knew what it could do. We all knew there were diseases around, but we never thought that it could take the shape that it did. So I think going forward, I think one of the biggest lessons learned, and when we say doing things differently, I think we should now definitely have a very strong surveillance system for emerging diseases, and also the technology that can support detection. Detection is going to be so important in the coming days. Now with this corona SARS-CoV-2 as an example, this is something I think we should take forward as a region, as individual countries. Use the technology. Rely on even modern technologies that allows faster detection, more accurate detection. Then be able to use that for surveillance purposes. I think that's something I wanted to add from the COVID experience. Thank you.
Thank you so much. Yeah. Any final comments before we close the session?
So I will share my reflections on our COVID experience.
Please do.
See, if you look at the data of the spread of viral infections like last 10, 20 years, we see that it is on the rise. And many studies project that this will keep rising. So we should be prepared for more such pandemics in the future. So here, what I find is that these kinds of pandemics can be addressed only through global cooperation. If one country decides to address it in isolation, it may not be possible. And the regional harmonies can even be broken. That was the situation in European Union that was facing. Some countries tried to amass the global supply of vaccines, and even within the European Union, other countries were not able to get adequate vaccines. So it was creating a environment that was not good in that region. So what I feel is that the lesson that I learned from this COVID pandemic is that we need to learn how to cooperate and coordinate our activities regionally and globally. That is the lesson that I learned from this COVID pandemic.
Thank you so much, Dr. Joseph. If there are no more questions, let me thank the organizers, for putting together such a distinguished panel. And let me thank all the excellent speakers. It was really a delight listening to you, very, very informative and insightful. I have to admit that I did not know a lot of things which were going on in our neighboring countries in terms of tackling COVID-19. So I think it was really, really insightful. And I hope, going ahead from here, we are able to develop research programs or other, cooperative mechanisms in which, we can cooperate as countries, as researchers, and, going forward from here. So thank you very much to the organizers, to the distinguished speakers, and last but not the least, to the very, very distinguished and patient participants who waited until the end and listened to, the various points of views here. So thank you very much to everyone here. Thank you. Bye-bye.
Thank you, Chair. Dear Chair and panelists, thank you so much for this wonderful session. It has been a very wonderful session because within this 2-hour time span, we have been able to cover a vast lot of topics which are very pertinent to the present problem that we are facing. With this, I would like to highlight that today, this session was the last session for today, but tomorrow from 11 a.m. Again, the session will start of the Bay of Bengal Economic Dialogue. And at 11 a.m., we have a paper presentation session on cross-cutting issues. So with this, I would like to thank the participants and the panelists once again on behalf of SANEM. And I would like to invite you to join tomorrow at 11 a.m. Thank you so much.
Thank you.
Thank you.
Thank
Thank
you.
you. Bye-bye. Bye-bye.
Thank you.
Bye.